Well, hi everyone. This is Dr. Michael Hochman, author of 50 Studies Every Doctor Should Know, published by Oxford University Press. And today I'm going to spend a little time summarizing the European randomized study of prostate cancer screening, which is probably the best study available summarizing the efficacy of PSA screening for prostate cancer. So let's dig into the details. So the European prostate cancer screening study asked a very simple question, and that is PSA screening effective for reducing prostate cancer mortality? The study was funded by several nonprofits, the European Union, and Beckman Coulter, which manufactures PSA tests, which presumably is some degree of conflict of interest at least. The study began in 1991. The most recent analysis was published in 2012. The study occurred in numerous sites in 7 European countries, so a multi-site study, with a sample size of over 162,000 participants. And at the most recent analysis, the median follow-up reported was 11 years. The study involved men between the ages of 55 and 69, and men in the screening group were offered PSA screening every 4 years. You may note that 4 years is a long screening interval, at least in the United States. When PSA screening is done, it's typically done every 1 to 2 years. And then PSA greater than or equal to 3.0 was used as a cutoff for biopsy. Again, that's notable in the United States at least. 4.0 is frequently used as a cutoff, so 3.0 is a little bit of an aggressive cutoff. And then additional treatment of positive biopsies for cancer was at the discretion of the treating physician. So in other words, the patient could be offered radical prostatectomy surgery or radiation therapy or watchful waiting at the discretion of the treating physician. Men in the control group were not offered screening. In the screening group, 82% of the men did receive at least one screening, and there was a mean of 2.3 screenings per participant. Not surprisingly, there was a higher rate of prostate cancer diagnoses in the screening group relative to the control group. So 10% of men were diagnosed with prostate cancer in the screening group versus 6% in the control group. And then here's the key slide looking at prostate cancer and all-cause mortality. So if you look at prostate cancer-specific mortality, rates were slightly lower in the screening group, 0.39 versus 0.50 events per 1,000 person years, and this was statistically significant. However, when you look at all-cause mortality, there was actually no difference between the groups. So based on these findings, the authors of the study concluded that 936 men would need to be offered screening and 33 additional men would need to be diagnosed with prostate cancer to prevent 1 prostate cancer death. So they made this calculation based on the fact that there was a substantially higher rate of prostate cancer diagnoses, 10% versus 6% in the screening group. However, there was only a very small reduction in prostate cancer-specific mortality and, of course, no reduction in all-cause mortality. So in other words, the study shows that there does appear to be a modest but significant reduction in prostate cancer-specific mortality as a result of screening, but it comes at a cost. And this cost is that there's going to be a lot more men who are diagnosed with prostate cancer and treated for prostate cancer, and many of these additional men who will be diagnosed and treated would never have become symptomatic during their lifetime. And of course, it's notable that there's yet to be observed an all-cause mortality reduction, because of course we don't screen for cancer to prevent prostate cancer-specific mortality, we screen to prevent all-cause mortality. Now there are some flaws to the study that are definitely notable. One is that there was a substantial amount of crossover between the groups, and in fact 20% of men in the control groups did end up getting screened out of the study protocol for prostate cancer, and this of course would have reduced our ability to detect a significant difference in mortality. Another flaw is that, as I mentioned before, there's 4 years is a very long lag time between screenings. More typically, there's a 1 to 2 year lag between PSA screenings, so may have missed some cases. But on the other hand, 3.0 is an aggressive cutoff point for biopsies, which would have led to a high number of false positive rates. Another flaw is that most men in the study underwent sextant biopsies versus what's more commonly used now, which is an extended core biopsy, which is more effective at identifying cancers. One other key study to be aware of on PSA screening for prostate cancer, there was a large United States randomized trial that did not show a benefit of PSA in digital rectal exam screening. However, again, there was considerable crossover in that study, and the European study is considered to be methodologically much stronger. So based on the results of the European and the United States studies, the United States Preventive Services Task Force currently recommends against screening for prostate cancer. This recommendation changed in 2012. Previously, they recommended a discussion with men about the risks and benefits, and now, based on the latest data, they're actually recommending against screening. The American Cancer Society's recommendations are a little bit more nuanced. They say that for men over 50 with at least a 10-year life expectancy, they should make an informed decision. However, screening should not occur without an informed decision-making process. In other words, you shouldn't just send PSA as part of a routine panel of tests that you send at an annual exam. You really want to make sure that men understand the risks, which are overdiagnosis and potentially overtreatment, versus the potential modest benefits. The American Cancer Society does note that discussion can be earlier for high-risk men. And that's the conclusion of the study.